Infection in central nervous system. Here mainly we are dealing with meningitis and encephalitis. There are other infections also like subdural abscess, empyema, and also transverse myelitis. But in your level, it's meningitis and encephalitis, which per se will be enough. What is meningitis? Inflammation of membranes of the brain or spinal cord. Dura arachnoid meta like this. Encephalitis, that is inflammation of the brain parenchyma. I am here not doing separately, just comparison wise. Brain parenchyma. Meningitis, it's only meninges mainly, but later it can go into brain parenchymal infection leading to as a complication encephalitis. But encephalitis per se, it's the inflammation of the brain parenchyma, presence at diffuse. It can be diffuse, it can be focal. That is neuropsychological dysfunction. Most common viral infection. Encephalitis, it's viral with parenchymal damage varying from mild to profound. Usually meningitis is bacterial in origin. About epidemiology, bacterial meningitis is a common disease worldwide. 5 to 10 per 100,000 people in USA. Men are affected more than women. Meningococcal meningitis is endemic in part of Africa as well as in Mecca. Incidence of viral meningitis is 11 to 27 per 1,000 patients. That is in world scenario, okay. But here about the USA, so it's comparatively don't. What the message is, bacterial meningitis is high compared to viral meningitis. Etiology, but bacterial meningitis, bacteroid, the anaerobes are there, fungi are there, parasites are there, but common ones are strep. It's depend on the age. That's the other important thing. If it is associated in a young, early neonate, it is group B streptococcus coliform, that is E. coli, and Listeria monocytosis. Those are the common because Listeria also associated with perinatal infection and it's associated with mother. Group B also same. E. coli can be in the mother's flora. So once in the children, it's different. What's about the young children, about 3 to 4 to 5 years, kind of infection varies. That is Streptococcus pneumoniae, Haemophilus influenzae, and Neisseria meningitis. Once in elderly also, it goes same manner. Maybe adding Listeria monocytogenes is there. And time to time, Pseudomonas can be there. About viral meningitis, enterovirus is the commonest cause of non-paralytic polio. Fungal and parasitic meningitis, so meningitis, what I said earlier, it is associated with immunocompromised population. What viral etiologies? There are arboviruses, herpes virus, enterovirus, likewise paramyxo. They are often present with encephalitis rather. In Sri Lanka, about encephalitis, arbovirus is there, Japanese encephalitis and dengue. Herpes virus is a commoner, that is about the encephalitis. Enteroviruses including Coxsackie, polio and echo. Other causes include varicella, measles, mumps, rubella, adeno, and rabies. These are for the encephalitis. So, arbo and herpes simplex virus, HHV67, any virus can cause virus, but if main thing is, we have to think, is it varicella or herpes simplex, HSV1. Viruses and severity of disease. You can see mild meningitis, severe meningitis, depends. Herpes simplex is the cause, that's why I am highlighting. Enterovirus, which can cause meningitis, which can cause encephalitis, but when encephalitis, herpes simplex is the one. Arbovirus also there. Seasonal distribution, just get the idea. About that non-infectious meningitis, it can be drug-induced, carcinomatous, serum sickness, or it's a medicine related, perhaps. Pathophysiology about bacterial meningitis. So it should reach while penetrating blood-brain barrier into the meninges or brain CSF. So there are different pathways. It can be nasopharyngeal colonization and mucosal evasion going over the tract. Leads to complement evasion of complement pathways. You have to recall why bacterial cross the blood-brain barrier to reach CSF. Perhaps mechanism is not completely understood. Maybe it's blood-borne infection which can go through the blood, penetrating blood-brain barrier and into the CSF. Here it's direct, maybe nasal olfactory frame and go to base of the skull. Or otherwise it can form the blood circulation. Anyway, host defense mechanism within the CSF are often ineffective. Bacterial proliferation leads to stimulate the convergence of leukocyte into CSF. That's why in bacterial meningitis, usually to other infections, if it is bacterial, leukocyte is high. If it is viral, lymphocyte is high. If it is parasitic, eosinophilic count is high. But T beats lymphocyte is high. Meningeal and subarachnoid space inflammation, release of cytokines as same as the inflammatory process, leads to meningeal and subarachnoid space inflammation. So that's what happens. Ultimately, it through cerebral vasculitis, edema, same as features of inflammation, increase intracranial pressure, increase CSF protein, dead and died neutrophils are there. So microbial debris is there, cellular debris is there, so high rich protein. Leads to cerebral blood flow. It in turn leads to hypoxia. Glucose transfer to CSF is low. That's why when we are checking as an investigation, CSF and random blood sugar, so it's less because consumption. And bacteria and leukocyte count also high. Viral meningitis and encephalitis. So how the root has same like skin, respiratory tract, GI tract, urogenital tract, infect blood to donor organs, whatever it can go. About the viral, so it goes with trigeminal nerve, herpes simplex virus, then nerve root it can infect. So viral replication can be hematogenous spread to CNS or retrograde transmission along neuronal axis, what I said, or direct invasion of subarachnoid infection lead to meningeal infection via olfactory mucosa. Bit of other viruses, Eastern encephalitis virus, just it's a zoonosis, that's what it is. So equine from viral encephalitis. So Japan, it's high. History of J, just get idea what is it was recognized in Japan, that's why Japanese encephalitis. So it's prevalent in South Asia, including East Asia, including Sri Lanka. That's why we are offering vaccine in 1 year. Most important cause of parvovirus encephalitis. It's associated with swine. So as well as it's a vector-borne diseases. Culex pseudovisnuani, the organism, vector, and it's amplifying host. So it's common in this part of country, that also northwestern and even NCP. So province, that's just to put the idea. So it's in our country, it's rice fields, also it is associated. Natural cycle, it's there, amplifying cycle, that's why it's a peak. Then it comes into where the Culex trichinorhynchus pseudovisnuani, so it can infect humans. Clinical features. So if a meningitis is classical infection, fever, headache, photophobia, nuchal rigidity, only present sign of meningitis in elderly persons, meningitism. But if it is in encephalitis, it is often associated with fever, headache, and alteration of the consciousness. So once consciousness is altered, it regarded as because it infect or affect brain matter. Physical finding vary depending on the host positive organism. Kernig's and Brutzinski signs are present. Maybe 50% of adult, not always. Ophthalmoplegia may be present. Likewise, systemic finding, maybe there are the focus of infection. Depends on that, we can think. Even endocarditis, arthritis, local infection like sinusitis, otitis media, mastocytitis. Likewise, so maybe cutaneous hemorrhages, petechiae. or if it is meningococcal meningitis, it's associated with these petechian hemorrhages. Usually it can isolate a focal neurologic deficit and seizure, but it's more commonly with encephalitis than meningitis. So usually meningitis, you have to appreciate always it associated with meningeal infection, and maybe it can spread to brain matter as a focal or diffuse manner leading to encephalitis. So usually HSV, herpes simplex virus encephalitis associated with dysphagia and seizure, difficulty speaking. West Nile virus produce myelitis, flaccid paralysis, clear sensoria, Guillain-Barré syndrome, and polio. Complication of bacterial meningitis. Immediate. It can lead to death, coma, loss of airway reflexes, seizures, focal or generalized, diffuse, cerebral edema, vasomotor collapse, DIC, respiratory arrest, dehydration, pericardial effusion. Bacterial meningitis in a delayed manner, same as ataxia, blindness, bilateral adrenal hemorrhages. It's associated with meningococcal meningitis mainly. Fatality rate for pneumococcal meningitis is high, 20 to 25. Higher fatality rate, seriously underlined concomitant disease, advance in age, prognosis. About the pneumococcal meningitis, residual neurological defect is always associated. That's a problem. About fatality, about compared to pneumococcal meningitis, listeria also high. Mortality rate in community acquired gram-negative meningitis is 20%. So if you give third generation cephalosporin, that's a treatment of choice. It will get viral meningitis, various complications related to systemic effect, like rubella. Usually all of these complications resolves without the sequelae. The outcome depends on infective agents. As I said earlier, viral encephalitis. Herpes encephalitis, 6 to 70% of mortality. Common sequelae, seizure, motor deficit, change in menstruation. TB meningitis, death in adult age 10 to 50%. Patient age, duration of symptoms before presentations. Focal ischemic stroke results from cerebral vasculitis. Here mainly it causes base of the skull infection as well, TB meningitis. It's typically present with similar symptom, low-grade fever, even in pyrexia, that is, and loss of appetite, loss of weight likewise. And associated, they requires maybe neurological procedures, VP shunt or drainage, ventricular peritoneal shunts to reduce intracranial pressure. Fungal meningitis, as I said, nowadays it's common because its immunocompromised population is rising. Abscess, papilledema, neurodeficit, seizures, bone invasion, fluid collection, direct invasion of optic nerve, ocular, and 40% cryptococcal meningitis. Usually ocular abnormalities are there. Diagnosis. What I said, now you know what is meningitis, what is encephalitis. Two different features. In meningitis, it's mainly caused by bacteria, while encephalitis is mainly caused by viruses. There are other TB meningitis, fungal meningitis. Clinical features, if it is meningitis, fever, headache. If it is encephalitis, fever, headache with alteration of consciousness. That is the peculiar features. Okay. Then etiological agents we discuss and complications. Then diagnosis. Diagnosis strategies mainly depends on lumbar puncture. This one way medical emergency, but prior to doing lumbar puncture, there are contraindications. It's in the platelet defects as well as presence of infection in the skin soft tissue at the puncture site. So we are invariably, once we are going to do a lumbar puncture, if it is surrounding vicinity of skin or soft tissue infected, then we are introducing infections to CSF. Even patients may be not having meningitis. Or other way, we are contaminating our sample. Other thing is, most important thing is we have to exclude increase intracranial pressure. We can use fundoscopy and papilledema. We have to exclude, as well as if it is can't suspect, it's always CT, computed tomography of brain is advisable to exclude brain herniation and due to rise of intracranial pressure. So that's TB. Oh, sorry, CT scan. Just get idea. In this level, when you are doing finals, it's very much important. This lecture will be helpful. CSF analysis. So opening pressure is there. Usually it's high in bacterial, TB, and fungal. There are also elevated tense in obese muscles there. Collection of fluid dose CSF. We prefer 3, maybe 5. Once lumbar puncture is done, we have to immediately analyze of turbidity, xanthochromia, glucose, protein, cell count, that is full report, gram stain, bacterial culture, Indian, it depends on, okay. Cell count and differential count in CSF is very much important. Then we do gram stain and bacterial culture. So there are maybe this PDF conversion, what I did, there are some alteration of term wording, but don't worry, that's CSF, that's it. Completely clear and colorless. That's we have to usually. So leukocytosis is the most common cause of CSF turbidity. Maybe protein also there. So first one, so once we have taken, we can send for full report. We have to check the white cell count. Pre-treatment, if usually this is white blood cell less than 5, polymononuclear, that's neutrophil less than 1, eosinophil less than 1, normal. But it can be abnormally high. So initial CSF analysis, lymphocytosis also there. Viral meningitis and encephalitis, usually cell count is less, nearly 100% are mononucleocytes, so lymphocytes. Early in viral infection, polymononuclear pleocytosis is there. Normal cell count and differential count reassured. Do not absolutely exclude bacterial meningitis. There are different type of cases, rabies, dengue, West Nile, herpes simplex, Nipah viruses. Likewise, there are broadly. Also traumatic LP. We have to presence of clot as well as CFC from traumatic LP 1 WBC to 700 RBC. So usually RBCs are less, but if it is this way, so it indicates traumatic. Or maybe clot is there. Decrease RBC count from tube 1 to 3. That also red blood cell count. That also indicate traumatic. So first one we have to do is the CSF full report. Then we do separately protein, glucose. Meanwhile, we have to do a random sugar. Then we do a gram stain and separately for the culture, because if we contaminate, that will be the problem. So usually, if it is prior treatment, gram stain may be there, but culture ability is very much less. So based on this gram stain, now you know about these characteristics, we can identify. Xanthochromia, that is, it indicates lysis of RBC and release of breakdown pigments. Oxhemoglobin, bilirubin, begin within 2 hours. So we have to exclude. That's why we are keeping CSF in one CSF sample in lab bench to exclude xanthochromia, to exclude traumatic tab, increase CSF protein, no more subarachnoid hemorrhages. Other thing is we can exclude subarachnoid hemorrhage. If xanthochromia there, we have to think is it subarachnoid hemorrhages. Glucose level is very much important. It's bacterial meningitis, usually CSF glucose is less because they consume. So this is the ratio, CSF glucose to serum, 0.1 to 1. If it is less, so it indicates bacterial more towards. Mild decrease CSF glucose, that's the thing. Then we can think, is it parameningeal process or viral? Usually bacterial or fungal, it's less. Glucose is less. Serum glucose is less. Protein, usually this is the value, 15 to 45 milligram per deciliter. If it is elevated CSF protein, usually higher than 150. Think meningitis, and if it is more than 100, like we think it is TB meningitis. If it is very high, it suggests fungal disease. So meanwhile, we apart from gram stain, we do in the preparations, we can see halo appearance, cryptococcal disease. More definitive diagnostic test is cryptococcal antigen, but we can see lactic acid dose on it's not done much. Antigen detection also nowadays we are performing. Counter immunoelectrophoresis, latex agglutination, agglutination. Based on that, we can do HSC. And also, but PCR is much sensitive. But we can do for the fungal antigen as well as pneumococcal, we can check. But HSC is usually PCR is the one. So about the culture, bacteriological culture, Neisseria meningitis, growth is there, Haemophilus influenzae there. But nowadays, anyway, bacterial culture growth is less. But we can appreciate is less, yield is less. So often we do PCR nowadays. For enteroviruses, we can do for encephalitis, but for the bacterial PCR it's not available much in our country. But we can do cryptococcal meningitis if we are suspecting in immunocompromised or HIV patient. So it's the same thing. Sensitive to detect CSF by PCR for Neisseria meningitis, H influenza is pneumonia is high. So there are other intracranial abscess. If it is intracranial abscess, it's a maybe complication of mainly meningitis as well as encephalitis. So different. So just TB or cryptomeningeal involvement. Dense likeness is there. MRI in HSC, you can see. Maybe further, if we are suspecting bacterial meningitis, we have to simultaneously do a blood culture as well. Then complete blood full blood count. Then chest X-ray depends on pneumococcal meningitis, TB, and EEG depends. EEG imaging study will be helpful to in encephalitis mainly. So meningitis, they are different: acute, subacute, chronic. Acute is often bacterial, subacute or chronic often associated with viral. Chronic, they are different. TB, meningitis, keep fungal CSF infection, and syphilis nowadays less. Management. Pre-hospital care, that is one way pre-hospital, other way supportive care. Here, first stabilization, so it depends. Okay, oxygen, vital sign. Assessment is very much important. Clinical history, as soon as take blood cultures and CSF plan and go for empiric antibiotics. Definitive therapy. Neisseria meningitis, penicillin will be penicillin, but depend on the ABST. Okay, Haemophilus always it's better kept Paxone. Maybe if it is resistant, we have to go with vancomycin. Listeria is AMP. This is about immunocompetent blood cultures. Likewise, okay. Here, what is common organism and what's antibiotic we should use? So in immunocompetent, these are the common organisms with the age less than 3 years and 18 to 50 years, more than 50 years, what I said earlier. So depend on that. Cellular and impaired immunity, cerebral fluid shunts, they are more prone to get Listeria monocytosis and gram-negative bacilli. Amphipas, Cept, depends, okay. Same way, preferred therapy, gram-negative cocci, vancomycin, penicillin G. So bacterial meningitis from gram stain, but we often, yes, it will helpful, but empiric therapy we often do is ceftriaxone antimeningitic dose. That is double dose. Then once we have in the susceptibility, ABST with the proper identity, we guide, which is MRSA, vancomycin. Likewise, same thing, but we are giving high doses and prolonged duration. This is the duration of treatment. Usually 10 to 14 days, 14 to 21 days, 7 days, gram-negative bacilli, we have 21 days. Maybe prolonged. There are indications for corticosteroids. It depends on the individual or patient care. So viral meningitis short begins self-limiting cause, complete recovery. Repeated therapy in 3 to 12, but it's not advisable always. Just to put. Intravenous acyclovir, we give 8 hourly. Then depends on it. It's the one we give mainly. Young cyclovir may be for CMV encephalitis. TB meningitis, corticosteroid decrease secondary complication. That's one. For the fungal, we give amphotericin B, fluconazole, miconazole, flucytosone. Flucytosone is not available. Chemoprophylaxis. Incidence of transmission of meningococcus is 5%. So household contact, if we are suspecting meningococcus, we give prophylaxis, rifampicin. Direct contacts. We may give ciprofloxacin or ceftriaxone. But pneumococcal meningitis, we don't. Haemophilus meningitis, we cure. Haemophilus influenzae, nasal colonization, who are suspecting to have in risk of developing meningitis. Vaccination is now it's given, even MMR and JE and Hib B. That's very much important. And TB or BCG vaccination will prevent mainly TB meningitis as well as miliary TB, not pulmonary TB. So always in meningitis, so we have to rule out non-viral cause, same as. Do not miss herpes simplex encephalitis, which is highly having effective treatment as well as if we not treat it, patient will inevitably die. Thank you.